already join. Welcome to today's Grand Round. Just a reminder that if you're not speaking, please mute yourselves and use the chat facility to post any questions for both the first and the second talks. I'm hoping that the speakers will speak for about 25 minutes, give or take, so that we have a few minutes at least for questions at the end. And without further ado, let's move on to the first presentation, which goes with the title Sticky or Sheared, and the diagram probably explains what we're going to hear about. And we have a number of presenters, Simon Demers-Marsil, and presenting on behalf of Jonathan Coles, Edward Needham, and Justin Cross. So away you go.
Thanks for having me. So today's Grand Rounds will focus on two interesting patients we had over the summer of patients infected with COVID-19 that developed large hemispheric strokes. And we'll go over the clinical aspects of those cases. I'll let Justin Cross, a neuroradiologist, go over some of the clinical pearls associated with the radiological findings. We'll look at some of the management guidelines of those types of stroke, and we'll look at the literature, a literature review looking at the epidemiology and pathophysiology of strokes in COVID-19 patients. Her first patient is a 59-year-old female, was admitted on August 15th with a worsening shortness of breath. She had not been COVID vaccinated, and she was desaturating on room air, 87%. So she's admitted to hospital, and she's found to be COVID positive, and she's treated with dexamethasone, tocilizumab, and also tazocin for a possible super infection with a bacterial germ. And she's initially receiving more and more oxygen, but the big event happens 1 week in when she's found with a new left hemiparesis, a right gaze deviation, speech difficulties, and a decreased level of consciousness with the Glasgow Coma score of E3V4M6. And she had been previously seen normal 1 hour previously. So she's quickly sent to the CT scanner, and there's no intracranial bleeds that are seen, and I'll let Justin go over the imaging later. But based on this, she received thrombolytics within 2.5 hours of developing symptoms. And there's a question of whether or not she would receive a thrombectomy. And she's actually accepted for a thrombectomy, but two things happen. One is that there's delays with the helicopter and ambulance transfer. And the other thing is that there's a period of hemodynamic instability where she's bradycardic. So there's a decision to not proceed with the transfer at that point. So no thrombectomy. However, because the occlusion is very proximal, there's felt to be a very important risk of malignant edema. And there's a phone call made to the neurosurgeons here at Addenbrooke's in the setting that she might need an hemicraniectomy. So there's a decision to transfer her here for that. So from the peripheral hospital to Addenbrooke's, she arrives at about 3:30 in the morning, which is less than 12 hours following the stroke. And on admission here, she's E1V1M6. She's not intubated, and there's a decision that's made at that time to watch and wait. Here are some lab values from her arrival at Addenbrooke's, where she has a very elevated D-dimer, an elevated CRP, slightly decreased fibrinogen, and an elevated prothrombin time, all things that you might see in a patient with COVID-19. So she arrives at 3:30 in the morning, and 4 hours later, she's found to have a newly decreased level of consciousness, and she's now E1V1M1. She has a dilated right pupil, which is unreactive, and there's a decision to quickly intubate her, give her hypertonic saline in the setting that she probably has elevated intracranial pressure. And without even doing a second scan, the patient is sent straight to theater for a decompressive hemicraniectomy. Following the hemicraniectomy, she improves slowly, She's extubated 11 days following her arrival, and she's transferred back to the first hospital about a month later. At that point, where she goes back to the referring hospital, she's able to eat by herself with her right hand. She's able to speak, to swallow. She's a bit confused. And she's hemiplegic on the left side. On the Rankin scale, which is the scale commonly used to describe functional status following a stroke, she would be classified as moderately severe disabled. So I'll now let Justin go over some of the imaging.
Okay, thanks, Simon. Okay, so just got some slides showing the CT scans and some vascular imaging on these patients. This is just to show a normal CT that I'm sure you'll be familiar with. So on the left, we've got an image through the basal ganglia showing a caudate nucleus, internal capsule, lentiform nucleus, insula, and then these three parts of the middle cerebral artery territory involving or including the frontal lobe and the temporal lobe. So these are the areas that we look at when we're trying to calculate an aspect score to see whether any of these areas show abnormal edema. At the front, the A here indicates the anterior cerebral artery territory and the P posterior cerebral artery. And then these just show images of the CT, of a normal CT angiogram, showing the circle of Willis here. So you can see contrast on this MRA or flow-related signal in the distal carotid artery, middle cerebral artery, anterior cerebral artery. And these show the different segments. So as the thrombus travels more distally, they are harder to recover using thrombectomy. So usually the targets for thrombectomy are in the distal carotid or proximal MCA. So this is the patient CT scan. So on the left of the screen, you can see the initial CT, quite subtle changes on the CT scan. You can see a little bit of high density in the right MCA that suggests some thrombus. The adjacent parenchyma looks a bit low density, not the best quality images. It's difficult to see whether there is evidence of an early infarct. There may be some abnormal low density here in the insula. And this is the CTA taken more or less at the same time. Following the contrast administration, you can see the right carotid artery, anterior cerebral and middle cerebral artery are not filling. That suggests occlusion of the right internal carotid artery. And there's quite good filling of the left middle cerebral artery, anterior cerebral artery, and of the posterior cerebral arteries. So that was the initial CT and CTA. And then this again shows the initial CTA, slightly different level. You can see some early changes here with some low density in the insula. There's perhaps a bit of low density in the right caudate nucleus. So that would give her an aspect of about 7 or 8. But actually, that there was a very substantial underlying infarct, and this was the CT from 4 days later, showing the complete MCA infarct, and it's also involved the anterior and posterior cerebral artery territories, suggesting that they've been occluded, probably posterior cerebral artery by raised intracranial pressure compressing the posterior cerebral artery on the tent. We saw the anterior cerebral artery wasn't filling well on the CTA, so that explains the anterior cerebral artery infarct. And she had some imaging of her neck vessels done as well. So these are volume rendered images. So they're quite busy images, but on the left of the screen is the right carotid artery. So this is the common carotid artery coming up from the aortic arch and dividing here into the external carotid artery with its branches and the internal carotid. The internal carotid forms this sort of stump with a kind of flame shape to it, and slight irregularity. This pattern where the arteries are occluded a little bit away from the bifurcation is suggestive of a carotid dissection with in situ thrombosis of the internal carotid. This was the left carotid bifurcation for comparison. So this is what it should look like with good filling of the ICA. And then this is, again, just from the axial images from that CT angiogram on the right-hand side. You can see a kind of a crescent of contrast. So that's the residual lumen, and most of the vessel is occluded by thrombus. Again, that's quite suggestive of a ICA dissection. Next slide.
I'll now introduce our second case, which was a 45-year-old male, so even younger than the first one, and who's known to be fit, who had received one dose of his vaccine and was treated for an upper respiratory tract infection at the time of presentation. So what brings him to the hospital is that he awakes at 2 in the morning and he's found with a new right hemiplegia and an expressive dysphagia. At the time he shows up to the emergency department, he's now E3V1M6, and he's found to be COVID positive. So what was initially thought to be a bacterial respiratory infection was in fact COVID-19. And because of the clinical findings, he's quickly rushed to the CT scanner and he's found to have no bleeds. And he's administered thrombolytics, as in the first case we've seen. In this patient, he's not known to have been referred for a thrombectomy. And those are in his initial labs, which I'll go over quickly. So he's in his peripheral hospital. He received thrombolytics, and 24 hours later, or just about, he develops a new worsening level of consciousness. So he had showed up initially with a GCS of 10, but he had improved in the meantime. And he's now found with a GCS of 8, E2V2M4. He has a left gaze deviation, a right hemiplegia, and he also has a new left pupil dilatation. So he's quickly intubated, he's given mannitol, and he's sent to the scanner to see if there's a new bleed or to find an additional reason for his new clinical change. And what's seen is that there's evolving left MC infarct with significant edema. So there's a call made to Adam Brooks with the neurosurgical team to transfer the patient directly to theaters to proceed with an urgent decompressive hemicraniectomy. When he arrives to theater, something a bit unfortunate happens, which is when he's disconnected from the ventilator and put on the anesthesia machine, there's a period of significant desaturation down to 45%. And I'm sure you can appreciate how in a recently injured brain, this can be injurious, but it was found and a chest x-ray was done, and the findings was that there was a right upper lobe collapse. So the patient quickly received a bronchoscopy and things improved. Following the hemicraniectomy, sedation is stopped and the patient is evaluated clinically for the next 2 days, but he doesn't improve. The pupils stay unreactive, and he has a GCS of E1, M1, sometimes M2, and there's no corneal reflex, no Tourette reflex, and he has these intermittent myoclonic jerks. With this concerning clinical findings, he's sent for a repeat CT, And what's found is a devastating brain injury, which I'll let Justin go over later. But based on the clinical findings and the new imaging findings, it's felt that he has now an injury with very severe consequences, and there's a shift to comfort care. So the patient is extubated and he dies shortly thereafter. So I'll now let Justin go over the imaging.
Thanks, Simon. Okay. All right, so the findings are similar to the previous case, so I'll just run through those quickly. So the initial CT, you can see it on the left of the screen. This is an unenhanced CT. You can see some high density in the left MCA, so that suggests thrombosis of the MCA. And on the CTA done at the same time, you can see contrast in the right carotid termination and right middle cerebral artery, but there's no filling of the left middle cerebral artery. You can't really see the anterior cerebral arteries on that image, but it suggests a carotid occlusion on the left side with MCA occlusion. So this was done, I think, a few hours later. You can see that the infarct on the left side has evolved and developed. There's now a lot of swelling with the midline shift. So the midline is pushed over to the right. There's some early dilatation of the right lateral ventricle. So it has the features of an acute left MCA infarct, despite the thrombolysis. And just showing the initial images and the images after surgery on day 2. If you go back to the initial images, a bit like in the other case, you can see some subtle low density, so that the basal ganglia on the left are not as well defined as on the right. The insular cortex is a bit low density. So this would give him an aspect score of about 6 or 7. So it suggests a reasonable size MCA infarct, but the subsequent imaging has shown really a complete MCA infarct. And similar to the other case, the posterior cerebral territory has also been involved as a result of the severe pressure and midline shift. The anterior cerebral artery territory, you can see, is spared. And the craniectomy, he's just has given him a little bit more room, so he's just bulging through the craniectomy defect, but there's still midline shift on that image. Just going back to the vascular imaging, we've made these reconstructions. So these are really the same image in color and in black and white. You can see on the right side, good filling of the common carotid artery here coming up from the aortic arch. This is the external carotid artery, and the internal carotid artery is filling well on the right side. On the left side, the common carotid artery is normal, and the external carotid artery also looks normal, but the internal carotid artery comes to this, well, there's just a stump of the artery still filling, coming to a point here. So similar to the other case, that this is very suspicious for a carotid dissection with occlusion, maybe a centimeter cranial to the carotid bifurcation.
Thank you. We've just looked at 2 cases of internal carotid dissections leading to large strokes requiring a decompressive hemicraniectomy. To just quickly go over some guidelines, both patients received thrombolytics within 4.5 hours. Actually, it was within 3 hours. So that's in line with the guidelines we have. Neither of the patients got a thrombectomy, and there's some challenges with doing thrombectomies in peripheral centers. But they should have been offered in those cases because they presented within 6 hours. And you can actually extend the 6-hour duration up to 24 when there's salvageable brain tissue shown on imaging. The challenge is that to show that there's salvageable brain tissue, you need special types of imaging, so CT brain perfusion and MRI with DWI sequencing. And that's not available everywhere. And both patients did get a craniectomy. The topic is a large one, craniectomies in malignant strokes. It can be considered within 48 hours, which happened for both patients. And it's something that's associated with a large survival benefit, but survivors are often left with significant disability. What do we know about COVID-19 and strokes? If we first look at the data in the UK, here's a study that's called the coronal nerve studies, and it looked at the neurological manifestations of patients with COVID-19. And what you can see in here is that cerebrovascular complications are the most common. And among these, ischemic events are frequent. And multi-vessel and large vessel occlusions constitute the bulk of the ischemic events. From the same paper, you can look at this bar graph comparing in gray strokes in non-COVID patients to stroke in COVID patients. And you can see that COVID patients tend to be younger, have more comorbidities, and are also more likely to die following the stroke, because an MRS of 6 is actually equivalent to death. The next few slides are provided by Dr. Nannoni, which we thank for her involvement in this presentation. And this data is from a paper she did with Dr. Marcus. And it shows that the overall incidence of stroke in patients hospitalized with COVID-19 is about 1.4 per 100 patients admitted, so about 1.4%. We often compared COVID with influenza at the beginning of this pandemic. We know that sepsis is associated with an increased stroke risk, but not all infections are the same. And if you look at COVID, it's about 8 times more likely to cause a stroke than influenza. So here are some of the numbers you can remember. So about 14 out of every 1,000 patients, or about 1.4% of patients with COVID-19 will develop strokes in the patients that are admitted. And often large vessel occlusion, younger patients compared to typical stroke patients, and multi-vessel occlusions. And why this happens is still under investigation, but we know that COVID-19 patients are prothrombotic, and they also exhibit a certain proportion of endothelial dysfunction. This happens through a variety of mechanisms. One of them is the coagulopathy that's involved with COVID. The other one is that they develop antiphospholipid antibodies. We're not sure about the clinical relevance of those antibodies, but they're there. And then the endothelium gets damaged by the inflammatory cytokines associated with COVID-19, and also by direct viral invasion, which causes endothelitis. Finally, the patients are often hypoxemic and requiring supplemental oxygen, which has the potential to worsen the initial ischemic brain injury. And then the treatments are also associated with strokes. For instance, ECMO is a predisposing factors to stroke. For arterial dissection, which was the mechanism for the strokes in both patients, the data is a bit less clear. We know that cervical artery dissections are a common mechanism for strokes in younger patients, and both patients were a bit younger. We know that dissections are more common at the time of infection, And we know that this association is independent of the fact that patients sneeze, cough, and may vomit because of their virus. So it's not only mechanistic factors. And looking at some pathology specimens of carotid arteries of patients infected with COVID-19, we were able to see that the virus was present within the endothelium. So is that a triggering factor for dissection? I think the future research might be able to highlight that. So in summary, we saw 2 cases of large hemispheric strokes associated with COVID-19. Both had hemicraniectomies. One patient unfortunately died, and the other one was left with a significant disability. The title of this presentation was Sticky or Sheared, because we initially thought we had a patient with a thrombosis and a patient with a dissection. And when we reviewed the imaging with Justin, we saw that they both had features consistent with dissection. So I think it highlights the importance of not focusing only on the sticky aspect or the procoagulable aspect of strokes in COVID-19, but also on the other possibilities, including shearing mechanisms for strokes or dissection. So strokes that can be sticky and sheared. And that's it. I'll be happy to hear your questions and comments.
Thank you very much for that very clear presentation of 2 obviously pretty tragic cases. And you've made the point very clearly that the mechanism only emerged on late review of the neuroradiology, and particularly the arterial neuroradiology. Have you had a chance to talk to other regional neurocenters to see whether they've seen a similar phenomenon? If they examine the patients with COVID who presented with large MCA strokes, and then they retrospectively reviewed the imaging, are they seeing dissection as an underlying mechanism at all?
You know, we actually have Ed Needham here who helped us prepare this presentation and who might have an answer.
Yeah, thank you. So I've certainly heard of other patients with dissection in COVID-19. I think at the moment it's very much reports, and there hasn't been demonstrated a significant increase overall, although obviously that has its difficulties in doing. What has come out of the stroke literature in COVID is that a lot of these strokes are large vessel, and they're often classed as idiopathic, so they haven't found any obvious precipitant. Whether that's people haven't looked hard enough for dissection, or whether truly these are just happening as sort of spontaneous thromboses is very difficult to know.
Thank you. A question from Stephen Saucer. Were the hemicraniectomies done too late?
So you will realize that the idea of the hemicraniectomy is to prevent the malignant swelling that then causes compression of the posterior cerebral artery, etc. As you described the cases, one got the impression that perhaps that event had already occurred by the time the hemicraniectomy was done. So these cases, it's always about trying to predict who might swell. Do you have any thoughts on how we might do better at predicting which of the patients actually need to be done? Because while you can do it up to 48 hours, and that's the trial data, we know that most of the patients that benefit are those who get it done before they actually swell, which means we have to predict who's going to swell.
I think the decision to proceed with the hemicraniectomy is a very difficult one. And there's some guidelines to help us identify which patients might benefit better. And I think it's a multi-disciplinary discussion that also should involve the wishes of the patient. In those specific cases, looking back, I think one can certainly wonder if intervening earlier would have been beneficial.
Particularly the first patient seemed to have anterior cerebral artery problem. I don't know, Justin, whether they weren't cross-flowing from the other side. But did they have an ACA that was working?
Yeah, they didn't have good cross-flow from the other arteries.
Yeah.
So I think that was the problem in the first case.
So incomplete circle of Willis makes you a bit more vulnerable to this type of problem. If you block off an artery and your circle of Willis is incomplete, then you're much more precariously balanced.
Certainly. Dr. O'Donovan has asked whether there's any evidence of COVID infection of the arterial media, not just the endothelium. Is that known?
I'm not sure. There's been one good paper where they look at 32 pathology specimens. Maybe Ed, you.
Yeah, I have to say I don't know the 100% answer to that. It's the endothelium is the area that's been focused on it, and many different groups have described an endothelial infection, but also endotheliitis, which may occur independently of direct infection. Whether the media itself, and I guess that you're thinking of the mechanism of the dissection itself, I'm genuinely not sure. It hasn't come out strongly.
And we must move on. Paul Edelstein's asked 2 questions, but I'll just ask one of them. If the dissection had been detected earlier, would there have been a different approach?
No, so the acute management is very much the same, and I mean, whatever the cause, even if it's an embolism from the heart or from a large vessel, it's thrombolysis, thrombectomy if you can, and then decompression. And as Professor also mentioned, it's that timing of decompression is the difficult thing, and you only know after the event's happened whether you did it right or not. And obviously with these 2, it'd been better to do it earlier, but the retrospectoscope's obviously a useful tool.
Isn't it? Well, look, very, very interesting. Raises lots of interesting questions about this interesting disease. Thank you very much indeed. We must move on to the second case, which is going to be presented by Dr. Chris Wall on behalf of Katrina Bagra. Desmosomes aren't just for dermatologists, a rare case of cardiogenic shock. So I'll notice that there's cardiologists who know about desmosomes. That's something for the headlines tomorrow.
Thank you. Yeah. So I'm Chris Wall. I'm one of the cardiology registrars, and I chose this title because certainly when I learned about desmosomes, it was only in the context of pemphigoid vulgaris and bullous pemphigoid. So I was surprised to see that even as I've come over to cardiology, it's following me here. And so I just wanted to start, with presenting a case of a gentleman that we saw in resource, which is this 42-year-old gentleman with no other past recent problems who'd recently come back from Barcelona. He had a nice time out there, but while he was there, he got a little bit breathless, and then he thought he'd find his way home. On the way home, he had kind of standard coryzal symptoms of diarrhea, vomiting, some myalgia, a little bit of left-sided chest pain, but nothing that sounded too worrisome at the time. And aside from this, there's not much to his other past social history, bit of a light drinker and a keen and active runner. In terms of his family history, his father had an MI at a relatively normal age to have an MI, and his sister had a cardiomyopathy in her 40s, which was thought to be H1N1 myocarditis, so kind of a flu myocarditis. Just going a bit more from the cardiac side of things, in terms of what he was like on examination, he'd had some more orthopnea over the last 2 days, so breathlessness when he's lying flat, and this intermittent kind of left-sided niggling chest pain, nothing that was crushing or central or too worrisome. And his heart rate was 140, blood pressure was okay, and examination of his lungs showed some crackles at the basis. When we go through his initial investigations, though, we're probably a bit more worried, and we can see that he's got quite a low sodium at 122, which is a poor prognostic sign in heart failure. But what's most impressive that jumps out at you is that lactate of 6.8, quite an impressive lactic acidosis. An elevated troponin, but probably not something that would be so out of keeping in someone who is septic or otherwise very unwell. And then quite deranged liver function tests. And then an elevated D-dimer and elevated pro-BNP, so a good marker of heart failure. Something I just want to quickly mention while I'm here is that although the troponin is elevated, certainly the BNP is much more impressively elevated. So this would be kind of a not uncommon history for someone who's coming in potentially with heart failure. This was his initial ECG, and I think, although I'll come back to this a little bit in the future slides, I think at the very least we can certainly say this is quite an abnormal axis, and at the time this was called atrial flutter with non-specific interventricular block. Going forwards, the initial impression was that it's probably either a myocarditis or cardiomyopathy, and I think there's a reasonable reason they came with that conclusion. He's got high CRP, and he's coming with heart failure-like symptoms, and he's had kind of coryzal viral symptoms over the last few days. Because obviously he's got a high D-dimer as well, PE and late presentation MI are also considered. And we plan some more next stage investigations, which is CT scan of his lungs, some blood cultures, a bit of a screen for myocarditis, which will come back at some point. We do a bedside echo, and because that ECG was overall pretty odd, we think we'll repeat it. And this is just done 10 minutes later. So his repeat ECG, I think we'll go, as I said, we'll go through in a little bit more detail later on. But certainly, I think you can be quite convinced that that's sinus rhythm, and the rate is much better controlled. I think it's also fair to say that the limb leads are low voltage. That's lead 1, lead 2, and lead 3. And there probably is some anterior T-wave inversion as well. He has a CT scan, which, as probably we thought, but important to rule out, there was no PE. And but there was good evidence of peripheral edema and right heart failure. And we put the bedside echo probe on and showed that actually he has quite severe biventricular dysfunction with a quite severely impaired left ventricle and a severely dilated right ventricle, which is also severely impaired. The infectious diseases team give us a reasonable shot on a myocarditis screen, and we put him on some broad spectrum antibiotics. What I think is really important at this point is, whilst I think the diagnosis of myocarditis is still up in the air, what's certainly very clear is this guy's very unwell, and that lactate of 6.8 is not really going anywhere, and he's quite a young man. I wanted to quickly go through these echo images and just talk you through what they show as I go. So what you can see on the image on the left, this is a 2-chamber view. The right ventricle is in the front there, and you can see that that's grossly dilated. So that should be certainly smaller than the left ventricle, and it's just not moving very much at all. So it's both dilated and severely impaired. The left ventricle is lower down there. I think you could say that probably the wall thickness looks relatively normal, but actually the only real movement that you see during that is the flattening of the interventricular septum in diastole. And that's actually quite a good sign there of right ventricular volume overload, if you hadn't already got that from the CTPA. In terms of the function of the left ventricle, although I think in this cut it'd be difficult to just look at it and say that's dilated, I think you can quite convincingly say that its function is impaired. And similarly for the cut on the right, again, you can see the right ventricle on what's kind of on the left-hand side of this picture, which really dwarfs the left ventricle and is grossly dilated and certainly severely impaired. You just can't see a great deal of movement at all. And certainly at this point, this patient's back in sinus rhythm. The left ventricle looks a lot smaller in this cut, but still, I think you can be quite convinced that its function is pretty severely impaired. So going forward for this gentleman, obviously because he's looks like kind of he's in cardiogenic shock, the next step was to take him over to ITU, and we talked to the advanced heart failure team in Papworth, because sometimes they have facilities to support, and in some cases we end up transferring these people over. But actually when he went over to ITU, he stabilized quite nicely, and actually the first step in the management of these acute heart failures is to try and attain euvolemia, which was what was done. So he was given IV diuretics. He actually didn't need any inotropic support, and once he was euvolemic, he was then started on prognostic medication. So this is kind of our generic prognostic medication for heart failure. So in his case, it was bisoprolol, ramipril, and eplerenone. The next thing that we did while he was an inpatient was a cardiac MRI once he'd stepped down to CCU and was stabilized. At the time, that was reported as acute myocarditis, which fitted nicely with the clinical picture. But we'll go a bit more through the imaging later on. I think it's probably more suggestive of a dilated cardiomyopathy. He then stepped down to CCU, and because he's had this issue, and also his sister had this odd story of a cardiomyopathy as well, we refer him to clinical genetics. I wanted to quickly show through the initial cardiac MRI pictures. So I think these are very beautiful pictures just to show quite how severely impaired his function is. So the left ventricle is kind of on the right-hand side here, and the right ventricle is on the left-hand side. A bit confusing. I think what you can see is that both ventricles are not moving very well, and actually, certainly you can appreciate much better in this view that the left ventricle is dilated. And what you can see very nicely, I think, in this 2-chamber view is quite how stretched out this left ventricle is. And right at the top of this cut, you can see the mitral valve annulus, which is kind of gently being pulled apart as the left ventricle dilates. I think this is a really nice demonstration of what we call functional mitral regurgitation. Now I just wanted to go into the other thing that we can use cardiac MRI for, which is in characterizing the tissue of the myocardium. And I want to talk you through these 3 cuts here. So essentially what this is it's what we call late gadolinium enhancement, which particularly is useful for looking at fibrosis or scar in the myocardium. Essentially the myocardium should all appear dark, but certainly in these pictures, I hope you can appreciate that there's a band of brightness around the subepicardial layer, so kind of on the outside of the wall of the heart. And that bright band very much shouldn't be there. As we look down in different segments of it, we can see that bright band sometimes goes even into the mid wall of the myocardium. And this is indicative of quite extensive fibrosis of the myocardium. You can also appreciate this in the right ventricle, which is, although it seems odd, the structure on the left-hand side of the left ventricle in these cuts. And again, you can see this bright band of fibrosis. So then you get seen in clinical genetics a few weeks later, and we got a little bit more through his history. And it seems like his sister had a myocarditis when she was pregnant with H1N1, and afterwards she developed cardiomyopathy, and he didn't know a whole lot more about that. Also, when we go back a bit more through his history, his cousin on his father's side had a dilated cardiomyopathy at quite a young age. And when we sent genetic testing, we found that he had essentially a mutation in his desmoplaskin gene, which I've listed here for posterity, although I don't expect anyone to look it up. And essentially, what this mutation causes is it's a frame shift mutation in desmoplaskin gene, which essentially causes the codons to be read out of the normal order, and that inevitably means there's a premature stop codon. What this means is that the mRNA is essentially nonsense, and then that mRNA is degraded through nonsense-mediated mRNA decay. Overall, this leads to low DSP levels in the myocardium. He started on Entresto, which is our next line treatment for severe LVSD, and obviously we get in touch with his family to do a bit more testing. I thought it's interesting actually to see how his imaging changes over the course of the year when he's on appropriate medical therapy. Certainly, I find this quite remarkable, how actually we give him relatively generic heart failure treatment, and still, I mean, I would say it's very convincing that his left ventricle and right ventricle to a certain extent have recovered. Certainly, they appear much less dilated, and on quantification, this comes out with an ejection fraction of 42%, so quite dramatically better than his initial echo. Similarly, in the 2-chamber view, again, although it's far from normal, it's nowhere near how severely impaired it was. So quite considerable improvement in biventricular function. I think also you can probably appreciate that the structure of the myocardial wall there is quite crenulated in the left ventricle. But we'll talk a little more about that later. Something I did also want to point out is that although the function has improved quite significantly, certainly when we relook at fibrosis in him, actually he still has this quite bright band of fibrosis all around his right ventricle and left ventricle, both in the short and long axis. So actually it's not maybe changing the underlying process, which is this fibrotic process throughout the myocardium, but certainly it's still improving the function. In terms of the other things that we need to think about in this gentleman, so this whole this disease type is what we call a desmoplaskin cardiomyopathy, and I did mention very briefly at the start that he was quite a keen runner. There's certainly, obviously this is a pretty rare disease, but there are certainly some cases, and well, there's a good association between, or correlation between vigorous exercise and what we call arrhythmogenic right ventricular cardiomyopathy. But actually, when we look at this subtype, maybe exercises may not be as important, although there are some cases of recurrent myocarditis which might be triggered by exercise. What I really want to point to here is how, by identifying this specific gene mutation, we can give better patient care and more tailored patient care and better risk evaluation. I'll come on to that in a little bit. So that's exactly what I wanted to say here. So by actually establishing this as a DSP cardiomyopathy, as opposed to just an acute myocarditis, then we can see that actually his risk of ventricular arrhythmias, and we can predict his future progression to heart failure as well. So certainly it's a lovely paper in Europace, which shows that in patients with myocardial injury and in patients with myocardial injury and DSP cardiomyopathy, actually their risk of or their chance of surviving free from ventricular arrhythmias at 10 years is very low. And so it's a very good justification to put an ICD. Unfortunately, his chance of progressing to heart failure is also quite high. So we can also have a bit more of a think about what's going to happen to him over the next 10 years. And also, again, by identifying it as DSP cardiomyopathy, we can see how well he unfortunately ticks all the other risk factors for having a ventricular arrhythmia. And he has all of these things that increase his relative risk of being affected by ventricular arrhythmias. So we can very strongly justify putting an ICD in this gentleman. Going back through the case, I think there's some interesting points. I think what's really nice is how well our MRI imaging matches kind of the standard of a standard of cases from the literature. Again, you can see this nice demonstration of desmoplastic cardiomyopathy, showing that bright band of fibrosis around the edge, very much like our imaging. And going back through, actually, you can maybe see that original ECG that we saw, which overall was certainly very abnormal and was maybe, we thought originally was atrial flutter with interventricular block. When we look at the follow-up ECG only 10 minutes later, which actually is the gentleman's self-reverted back into sinus rhythm, probably the initial ECG was slow VT. And that's why the axis has changed so dramatically in such a short period of time. Whether or not that caused his decompensation, I think is up for debate. Certainly he cardioverted kind of by himself without any sort of medical intervention. So it may be that he was going in and out of VT. And I think probably it's more likely that an acute infection has caused this, and that's why he had a CRP of 120. And he was kind of flicking in and out of VT maybe over the last few weeks. Again, another strong justification for putting in ICD. So we've talked a little bit about this from an MRI point of view and from an ECG point of view, but I think, at least in my head, I find it interesting what these patients actually look like if you were to cut them open. So these are some histological samples of arrhythmogenic cardiomyopathy. And I think what I like about these samples anyway is you can see healthy myocardium on one side, and then in this case, it's on the right side, almost entire removal of the normal myocardium and replacement with this fibrofatty material. And you can see how this would cause dilation and impaired function, because actually the myocardial cells are just not really there, and they're replaced by structurally not very strong cells like fibrofatty tissue. I just wanted to quickly go through some of the terminology, because certainly it's changed since when I was in med school, which is we started off with this idea of ARVC. And as we've done more MRI imaging as a cohort in cardiology, we've started to appreciate this as an arrhythmogenic cardiomyopathy, rather than just something that only affects the right ventricle. And what I'm also going to tease out here is quite how a genetic diagnosis allows us to pick apart arrhythmogenic cardiomyopathy into actually the different genotypes that cause it, and quite how DSP cardiomyopathy is different. So certainly in the way that we used to diagnose ARVC, it was based on the overwhelming genetic cohort, which is these PKP2 mutations. I'll go a bit more through this in a bit. And so all of the criteria to diagnose it is quite well tailored to pick up those, but it's actually not so well tailored to pick up DSP cardiomyopathy. And actually, really, the DSP cardiomyopathy group are more proponent to arrhythmias. They have more chance of involving the left ventricle. They have recurrent episodes of myocardial inflammation, and it's got a worse prognosis associated with it. And yet the ECG features are not necessarily the same. So certainly the DSP cardiomyopathies which involve the right ventricle are likely to have this anterior T-wave inversion, which is certainly a feature of diagnosing ARVC. But if there's no right ventricular involvement, they're much less likely to have that anterior T-wave inversion. So much more difficult to pick up, to be honest. What I thought was really interesting about these ARVCs and all the genes that are involved is that all genes that are really just involved in the desmosome. And so I can see how this cohort links to actual structures in the desmosome there. And what I thought was interesting in this is it probably all shares a common pathway through desmosomal dysfunction. So I took a little bit of thought and went back to think about my previous diseases that involve the desmosome. And going back to pemphigus, I thought about, well, this is associated with antibodies associated with desmoglin. And then after a bit more reading, I picked up a few of the other desmosomal diseases, which is Carvajal syndrome, Naxos syndrome, which are cardiocutaneous syndromes. and then DSP cardiomyopathy, which is what this gentleman had. I thought it was quite straightforward to see how, well, if your desmosome is getting pulled apart, then your cell's getting electrically uncoupled and replaced by fibrosis. And it's quite logical to see how this would be something that ponders patients to arrhythmia. And it was also quite clear how this could possibly be associated with myocardial cell death, but I was less clear about how it could be associated with inflammation. I'll go a little bit more through this. So certainly one of the theories behind why desmosomal dysfunction is associated with myocardial cell injury is that essentially the cells get pulled apart and then they get damaged in that process, the apoptose, because they don't share that positive signaling. But actually, when I had a little bit more read about it, I was surprised that in these autosomal recessive types, actually a lot of the expression is in tissues which are not really undergoing a lot of mechanical strain. So it's interesting, these autosomal recessive types, actually their symptoms are actually, or their signs are in woolly hair and in palmoplantar keratosis, which maybe aren't areas that undergo a lot of mechanical stress. And these patients who have this autosomal recessive type of DSP cardiomyopathy, which is these two, they have much more aggressive cardiomyopathy that goes with it. So maybe it leaned me a little bit more away from the mechanical stress as a stimulant. What I thought was more interesting as kind of in terms of a possible cause was that essentially because these patients are going to have low DSP levels within their cells, simply because the mRNA gets broken down in half of their DSP, because it's an autosomal dominant disease. So one DSP is normal, one is abnormal. Essentially, they will have half the amount of desmoplakin. And there was some interesting work that had been done that caused desmoplakin deficiency in mice cells and what happens to their myocytes. And we found that when we knocked out desmoplakin, there was nucleotranslocation of plakoglobin, which is another desmoplakin protein, and that actually just caused the cells to essentially redifferentiate into adipocytes rather than myocytes. So maybe it's not a cell death process so much as a redifferentiation process. But I still couldn't really answer the question on inflammation, and I don't think I'm going to answer the question, but I thought I had an interesting answer nonetheless, which is there was an interesting paper published looking at whether or not, in a similar vein to pemphigus vulgaris, anti-desmoglein 1 and anti-desmoglein 3 are associated with the pathophysiology of pemphigus. It was interesting for me, at least, to see that some work had been done on looking at anti-desmoglein 2 in ARVC. And actually, at least in the purpose of this, albeit relatively early work, anti-desmoglein was well correlated with a diagnosis of ARVC in patients who'd already been diagnosed and was absent in control groups. And interesting, at least to me, was that the anti-desmoglein 2 level was also correlated with the burden of premature ventricular contractions, which probably is a risk factor for ventricular arrhythmias. And I thought that was interesting because maybe it's more than just a marker, but also participates in the pathogenesis of ARVC. So overall, in summary, what I thought was really interesting about this case, which you don't always get to say with these dilated cardiomyopathies, is that we established the true cause of what caused his dilated cardiomyopathy and what the underlying pathology was, and that has quite impressive and dramatic changes to his care, both in terms of inserting an ICD as well as planning for his future and his chance of progression to heart failure. It also has extremely significant implications for his whole family. And as we go back, certainly we'll be testing his cousin and his sister, and certainly it's very likely that what they really had was DSP cardiomyopathy. I think it is really important for us to, or very interesting for me to see how DSP cardiomyopathy is, or actually the whole of the ACM group are getting separated out into each of their genotypes, and each one is subtly different to the other. And we can't really rely on straightforward ECG criteria to make the diagnosis. Often they don't fit into that. And I think I would say that the exact mechanism behind this recurrent myocarditis picture, which we sometimes see in DSP cardiomyopathy, is unclear, but at least I'd be very interested to see where the work goes in terms of whether or not it has an autoimmune component. I think that's everything I have to say.
So thank you very much for that, Chris. I've just got a few questions myself. I may have missed it. I take it he doesn't have children. You didn't mention children.
Oh no, sorry, yeah, he doesn't have children. Yeah.
Okay.
Oh, Chris.
And
Chris, sorry to interrupt. He does have children. He's got two
Oh,
daughters.
sorry. Oh, sorry.
Yeah, he's got two daughters, Paul, who've been referred to genetics and to paediatric cardiology.
surely. And I mean, he's what, 42? So is he a candidate for heart transplantation? I mean, presumably without that,
Yeah.
prognosis is not great.
Yeah, great question, Paul. So he's 44 now. So he presented about 18 months ago, and so actually, really interestingly, and as Chris showed, he's responded very well to good heart failure medical therapy. His ventricular function has improved, as Chris nicely showed. What's concerning, of course, is that he's got a lot of scar affecting both ventricles, and so his ventricles probably improved as far as it's going to get, actually. And so I remain quite worried about him from a kind of future risk of heart failure and decompensations. So I recently arranged for him to have a cardiopulmonary exercise test done just to see what his VO2 peak was. And interestingly, he came out with a VO2 peak of 37 mils per minute per kilogram, which is really very good. Considering his imaging and what we know about him. So I was quite encouraged by that. He's on Entresto at top dose. He's got an ICD in, and he's NYHA1 at the minute. His BNP has come down under 1,000. So at the minute, he certainly is nowhere near needing a transplant, but it's something that we will definitely keep a very close eye on for the future.
And I mean, do you think, Katrina, that in retrospect, maybe he and his sister were pottering along with well-compensated disease until a viral infection comes along and just tips them over, perhaps precipitates an arrhythmia, and then off they go?
Yeah, great question, Paul, again here. So yes, I mean, that MRI that Chris showed at the beginning, where he's got severe biventricular dilatation, severe biventricular dysfunction, and all that scar. So what's interesting about that MRI when you go back and look at it again is that he did not have myocardial edema. And if he'd had really acute myocarditis with all that scar, his troponin would have been very much higher. You would have seen edema on the MR imaging, and in some of the case reports that are within the literature, they've also actually used FDG PET CT to look for that kind of acute myocardial injury. And some patients with DSP cardiomyopathy are actually diagnosed initially first as sarcoidosis, so there's that kind of overlap as well. But I think probably he'd been pottering along, probably who knows for how long, with the cardiomyopathy and significant biventricular dysfunction, as you say, possibly in and out of non-sustained VT with a viral illness, tipped him over to clinically present.
Very good. Just to read out a sort of discussion that happened in the chat for those who haven't been seeing it, Thomas Ha from Dermatology asked whether the patient had palmar-plantar keratoderma or woolly hair, which wasn't mentioned on presentation, perhaps unsurprisingly. And apparently the patient didn't, but the cardiologists have not yet met the sister. David Menon has asked whether anti-inflammatory treatment would be helpful, if there is a role for inflammation here.
So again, that's a great question. I don't know if Chris wants to answer that. I mean, I can start by answering that we don't have, it's a good question, but we don't have any data at the minute to support the use of, for example, steroids for the acute myocarditis component of it. I think it's something that would be really useful to look into in the future, but at the minute we don't have any evidence to support that. I don't know if you want to add anything, Chris.
Yeah, so certainly the paper that I cited there was a paper looking at the cohort of ARVC generally, rather than specific to DSP cardiomyopathy. I think in this gentleman where there was very little, well, there was no real myocardial edema, there wouldn't be this is not a flare of myocarditis that brought him in hair. And so in this context, certainly there'd be no scope for it. Whether or not at some point in the future we validate the role of anti-desmoglein in ARVC, then one can maybe look ahead of that. But yeah, I think probably there'd be no case to do it, certainly in this case.
And if I can, we're just slightly over time, but what's the frequency of mutations in this gene in the general population?
I wonder if Dr. Greg Miller is still on the line. He's expert in inherited cardiac conditions and an electrophysiology consultant at Papworth. If Greg's still on the line, he might be able to help us with that, Paul.
Yeah, hi, Paul. I don't know the precise answer. As with many of these cardiomyopathies, there is a degree of incomplete penetrance, so there will be asymptomatic individuals walking around with apparently likely pathogenic or pathogenic mutations in many of these desmosomal genes. But I couldn't give you a precise number. A very good resource for that to answer that sort of question would be the NOMAD study of more than 100,000 healthy individuals with whole exome or whole genome sequencing. You can look up the frequency of various mutations in whatever gene you like from that freely available browser.
I was just thinking, if it's fairly rare, this family's been very unlucky for a paternal cousin to have presented with it, and then for these two to have presented with it, assuming there's no family interrelationships. I didn't see a family tree, but then I would say that as a metabolic physician, wouldn't I? We've run a little bit over time because we've had two really interesting presentations. So thank you to both teams for that. And good afternoon to everybody. Thank you.
Thank you.
Thanks, Paul. Thank you very much. Thanks, Chris. Thanks, everyone.